A very good evening to one and all on this platform. I welcome you all to the 33rd Journal Club and Journal Scan conducted by Image. A very successful event attended by a large number of people across our country and around. We have a sort of a global audience. And today we have an interesting article for the Journal Club, which is on daratumumab with lenalidomide as maintenance after transplant in newly diagnosed multiple myeloma, the AURIGA study. And to do this, we have members from CMC Ludhiana and Professor Joseph John, who's the professor and head of hematology and cellular therapy in CMC Ludhiana, and also the associate professor for quality standards in CMC, is going to be conducting it. And his one of his faculty members, John Abraham, is going to be doing the journal itself. Followed by that, we will actually have our discussion and the expert comments. And we have the journal scan done by Dr. Himani Gupta from the Rajiv Gandhi Cancer Institute in Delhi, and then the quiz done by Colonel Uday. So with this introduction, I hand over to Professor Joseph John to go ahead with the Journal Club. Professor Joseph.
Thank you, sir, for the kind introduction, and it is a pleasure to be here on the 33rd Journal Club from Image. And today, CMC Ludhiana is hosting the presentation, and I have the privilege and honor to introduce Dr. John Abraham, who actually about 9 years ago did post MBBS 1 year house job with us, and later bitten by the hematology bug. And subsequently, he continued his pursuit, did his MD medicine in CMC Ludhiana, then worked here as a lecturer for a couple of years, and then went to Vellore and did his DM in clinical hematology, and he's back. And I'm extremely proud and privileged to have him here. Today, Dr. John will be presenting the Journal Club on the AURIGA study, and we are honored to have Dr. Badros with us, the first author of the paper, who would be listening to him firsthand and getting the review. And I will be discussing some of the critical analysis of the paper soon after his presentation. Over to Dr. John.
Good evening, everyone. I'm Dr. John. I'm an assistant professor in Department of Clinical Hematology in Christian Medical College, Ludhiana. I'm presenting today's Journal Club. This Journal Club article is taken from Blood Journal, which is the AURIGA study, which compared DARA with the LEN versus LEN alone as a maintenance agent after transplanting newly diagnosed multiple myeloma. We all know that the standard of care in transplant eligible myeloma is induction therapy followed by high-dose melphalan and autologous transplant, plus minus consolidation and maintenance with LEN. The challenge here is that we know that most patients would ultimately go on to relapse despite the treatment. So there is a need to improve depth of response and to improve long-term outcomes. So its optimization is required with respect to maintenance in multiple myeloma. What do we have data with respect to daratumumab in maintenance setting? We have the Cassiopeia trial, which showed better PFS and MRD negativity with the daratumumab in maintenance, but there was no LEN arm used, only daratumumab or observation after ASCT. Now, the Griffin trial had a DR versus R arm in the maintenance, which showed a better PFS and MRD negativity, but there was no re-randomization at maintenance, so couldn't isolate DARA's contribution in maintenance. Again, the same thing with Perseus, showed better PFS and MRD negativity conversion. Again, lacked maintenance re-randomization. A post-hoc analysis of Perseus showed that the MRD positive patient post ASCT had better conversion rate, that is 60.2% versus 40.5% with the DR. So this was the first suggestion that DARA retains a value in maintenance, especially if the patient is MRD positive. Coming to data with single agent len maintenance, we have multiple randomized trials. We have meta-analysis and real-world data that shows that single agent len gives a PFS of ranging from 40 to 50 almost, and multiple trials studies showing that MRD conversion rate of approximately 30 to 40% using len as single agent. Coming to MRD as a surrogate endpoint. Now, this is a critical meta-analysis that examined almost 3,000 patients with almost 2,000 MRD samples, and which concluded that MRD meets criteria for PFS surrogacy. And the clinical implications were significant with an impact on regulatory approval processes. And based on these data, the Oncological Drug Advisory Committee and the FDA has gone on to give unanimous approval for drug approval based on MRD as a surrogate for PFS. Now coming to Auriga study. Auriga study was a phase 3 randomized controlled trial which was conducted across the United States and Canada with 200 patients. The patients were transplant eligible newly diagnosed multiple myeloma who had undergone at least 4 induction cycles of induction and had at least a VGPR or greater response post-transplant and was MRD positive with a sensitivity of 10 raised to minus 5 by NGS method and was never exposed to anti-CD38 prior to randomization. The treatment arms consisted of the control arm was the len maintenance with starting dose of 10 mg with provision to go up to 15 mg if tolerated. After cycle 3, the DARA, the experimental arm had DARA and len with the DARA subcutaneous dosing of 1800 mg, which was initially given weekly, then 2 weekly, and then eventually every 4 weeks. The lenalidomide arm, the doses was same as the control arm. Ultimately, the patient would go on to receive 46 injection, that is from 36 cycles, 46 injection of subcutaneous daratumumab. The study endpoint, the primary endpoint was MRD negative conversion rate at 12 months, and secondary endpoints, they looked at PFS, so overall MRD negative conversion rate, sustained MRD negativity, complete response rate, OS, etc. Now, the time points at which the assessments were done, baseline post-ASCT marrow MRD was assessed, and at cycles 12, 18, 24, and 36. The statistical analysis was the primary endpoint was analyzed using Cochrane-Mantel-Hansel test, with which common odds ratio was estimated, and Fisher's exact test was used for two-sided p-value calculation. The sample size was calculated as 214 based on 85% or more power, based on an alpha of 0.05. However, only 200 patients could be recruited due to various challenges, which led to a final power of 84%. PFS was calculated using Kaplan-Meier curves using stratified Cox proportional hazards model, and nominal p-value was calculated using stratified log-rank test. Interim PFS analysis was planned with a nominal significance threshold, and a p-value of less than 0.015 was calculated for PFS at interim. However, in this study, at the time of analysis, the p-value attained for PFS specifically was 0.03, which did not cross the significance, that is 0.015. Coming to the consort diagram, total of 452 patients were evaluated, out of which 200 patients were finally enrolled in the trial, were randomized 1:1. 99 patients was allocated to DR group, while 101 to R group. 96 was treated in DR and 98 was treated in the R group. Ultimately, at the time of analysis, 33 in the DR had completed the study and 20 in the R group had completed the study. Coming to the baseline characteristic, both the arms had fairly matched out baseline characteristics except for cytogenetic risk diagnosis, which the high-risk group had, the experimental arm had more of high risk, that is 23.9% versus 16.9% in the len alone arm. However, when using revised cytogenetic risk, that is including translocation 1420 and gain or amplification 1q, the baseline character, the risk evens out. That is, high risk patients were 34.4% versus 33.7%. Coming to key efficacy results, the primary endpoint, that is MRD conversion rate using a 10 raised to minus 5 sensitivity method, was 50.5% in DARA-LEN versus 18.8% in LEN alone. And the patients achieving more than or greater to CR was 61.3% versus 25.8%. Now, looking at total MRD valuable population, that is any patient who had an MRD assessment at baseline and had at least one post-baseline MRD evaluation, also showed a better outcome with the DR, that is 56.8% versus 23.2%. Coming to subgroup analysis, all of the subgroups showed mostly favoring DR, except for the high-risk cytogenetics, which showed a confidence interval overlapping. So wide confidence interval, probably because the population of high-risk in the study was not very significant. The other endpoints, secondary endpoints that I looked at is deeper MRD conversion using 10 raised to minus 6 sensitivity, also favored experimental arm 23.2%, and complete response or better at any time was 75.8% with the DR arm. Now coming to PFS was also better for the DR arm, 82.7 with a p-value of 0.03. However, did not achieve the p-value required for interim analysis. This is the PFS curve showing that at almost 12 months, both the curves started separating. Now PFS by MRD status at 12 months. This curve showed that irrespective of how we achieve the MRD negativity, whether it is using DR or R arm, the PFS, the patients would do well with respect to PFS. That is, both the MRD negative patients had 95.2%, versus if the patient had MRD negativity, they would go on to have worse PFS, that is 69 and 59.3%, irrespective of what treatment they had received. So ultimately, to conclude, irrespective of what treatment they have received, achieving the MRD negativity would give us a better PFS. OS data at 30 months seem to not differ, that is 94.6 and 91%. However, the data is not yet mature at the time of analysis. Overall MRD negativity was more in the DR arm, that is 60.6%. Sustained MRD negativity at 6 months, 35.4, and at 12 months, 17.2, both favoring the DR arm. Now conversion to CR or stringent CR from VGPR, again 59.5% in DR versus 38.8%. That is a difference of almost 20.7%. Now coming to safety and adverse drug reactions. So as you can see, the DR arm had more cytopenic events and greater grade 3 or 4 cytopenic events than LEN alone. DR had almost 13.5% having an infusion related reaction. So key safety findings, most frequent adverse side effect with DR was pneumonia, just 4.2% versus 4.1%. Most common reason for discontinuation in DR was myelodysplastic syndrome, and most common cause in the R arm was peripheral sensory neuropathy. Overall, the DR group showed higher rates of grade 3-4 adverse events and discontinuation, but overall had a manageable safety profile. Now, coming to secondary primary malignancies, DR group had 7.3% versus 4.1% in the R group. Now, coming to discussion of the trials. What was the existing data and how the Auriga addressed it? As we had discussed before, Cassiopeia had no comparator harm. So this was addressed by Auriga. Auriga used lenalidomide as a control, which reflects a real-world standard of care. Griffin and Perseus did not have re-randomization of maintenance, so we could not isolate the effect of maintenance DARA in the maintenance alone. So here, Auriga addressed this by randomizing post-ASCT to specifically to test the role of daratumab in maintenance setting. All the previous trials had included both MRD positive and MRD negative. Auriga included only MRD positive patient. So most of the previous trials started randomization and diagnosis, but Auriga randomized after transplant with a known VGPR status, and only MRD positive patients were included in the trial. So Auriga was the first randomized trial which compared DR versus R in a post-transplant setting, and it showed an overall MRD conversion benefit and improved sustained MRD negativity versus its control, and better PFS benefit for the experimental arm, and thus supports an MRD adapted strategy, that is intensifying maintenance in MRD positive patient post ASCT. Because now coming to a break. This is a recent documentary I've seen in Netflix. It's called Turning Point: The Vietnam War, and I was fascinated by this gentleman. This is Mr. Robert McNamara. He was a Ford Motor Company president, and later he served as a Secretary of Defense to President Kennedy and Lyndon B. Johnson. So this gentleman was obsessed with numbers. So for him, more enemy casualties meant victory. But he failed to identify the psychological resolve of Vietnam Cong to resist foreign occupiers at any cost. Now, what was the result of this obsession with numbers? Millions of lives was lost, 10 years of war, almost $1 trillion was spent, and ultimately it was a strategic defeat for the US. Now, coming back to the Journal Club, what is the challenges of implementing this maintenance strategy in Indian and lower middle income country settings? Obviously, the first one would be the cost. The total cycles is 36 with 46 injection. The total cost would come around approximately 80 to 85 lakh per patient. Coming to logistical barriers, would require daratumab subcut would require hospital clinical visit every weekly, bi-weekly, and then monthly. We do not have MRD testing at 10 raised to -5 routinely available in India. So most centers would rely on flow cytometry or paraprotein tracking. Thus, it limits the ability to select MRD positive patients or to assess sustained MRD negativity. We know that the higher infection rates in India and the low middle income countries are higher. DR increases risk of neutropenia and infection, and overall will increase the health burden on healthcare system and overall healthcare expenditure. Now, to summarize, DR maintenance significantly improved MR negative conversion. Increased MR negativity was associated with improved PFS. Findings were consistent with the Cassiopeia, Griffin, and Perseus study showing DARA maintenance benefit. DARA maintenance did not result in any unexpected safety concerns. The study supports adding DARA to standard of care R maintenance in specific newly diagnosed multiple myeloma patients. Future studies are needed to confirm benefit after DARA-based induction and to determine optimal treatment duration. Cost, logistic, and infection risk may preclude wide-scale implementation in lower middle-income country settings. Thank you.
Thank you, Dr. John. And with the permission of Dr. Lieutenant General Velu Nayak, shall I go ahead with the
Yeah, please.
discussion, sir?
Please, Joseph.
Yeah. So I have a few slides to share in the context of it. Yeah. So basically, Dr. John elaborated on the entire the study, the pros and cons of it. Mine is a critical analysis, and obviously, this is an armchair analysis and not having done it and been there. Dr. Bardos has done it, and so he would have more insight into this. And nevertheless, my aim would be to give a opposite view and see, critically analyze and say what went good and what could have been better, or maybe how to interpret the data in a more critiquing manner. So the problem addressed is the maintenance optimization. The key points is that it is an Auriga study, another of the constellations from the daratumumab studies. And I would like to look at this critically on the FIRAC framework, which is a legal framework which we use on the facts, issues, rules, analysis, and conclusion. And the facts here is that this is a sponsored study. It's a Janssen Research Development Study, and Janssen is making good way in the multiple myeloma treatment. When you look at the external aspects of Janssen, it has come up with the number of approved therapies of 5, way ahead of other companies. And in the stock market, it is doing very well. And if you look at Darzalex, Revlimid was highly priced in the US, and it was critiqued by many people, including Vincent Rajkumar, and they were making pretty high strides here. And then the profit margins have come down. Obviously, it is priced less, but Dara is picking up very high. And if you look at the growth over time in the stock market shares, and if you look at BMS versus J&J, J&J is this dark blue and the light blue is the BMJ. And it is prediction wise also J&J is looking good. So which means that the data is there to stay and more of these studies are going to come in. And we looked at MRD, and MRD was evaluated on odds ratio based on the CMH analysis they did, Cochrane-Mantle Hansel testing with a binary outcome logistic regression, but they chose to use OR. And the complete response rate was better, and that again, the OR was higher, and the progression-free survival, the hazard ratio correctly used as per the Cox proportional hazards. And the incidence of grade 3, grade cytopenias were slightly higher. However, no statistical difference was shown, but it was slightly higher is what was mentioned. And we must understand the overall survival is not mentioned there. So when you look at the outcome, the effect estimate, if you look at, these are the conclusions, and the CR, we are getting an absolute gain. So when we look at studies, we must also look at the absolute difference. And there is a 31% absolute difference in the MRD, and the CR is about 15%. And there is a 47% advantage of the 30-month PFS. That's the key points in this paper. So that's a conclusion. It improved MRD, and therefore it is a surrogate marker, and it is a surrogate marker, and therefore it would then translate to an OS. So this study was registered under clinical trial, and we looked at the clinicaltrial.org and how it has been designed initially. It is a parallel, it's a parallel assignment, the randomized study, open label, and these were the registrations from 2019 and last verified in May 2025. John went through the design, the population, the intervention, the comparator, the PICOTs. I would be looking a bit more into the settings, the statistics, and the concept of magnitude of clinical benefit scale. So 73 locations as per the clinicaltrial.gov, 21 authors from 16 institutions, 2 countries represented, mainly Caucasians. What do we look at these statistics? We looked at one of the aspects is this is a prospective randomized study. Why did they use odds ratio, which they usually must be using it in case control studies, and why not a risk ratio? So this is a study which came up and looking at, authors are using odds ratio. It is not wrong. When there is a binary outcome and we are using logistic regression, you can use the odds. However, we must understand critically, odds can give you a exaggerated value higher than the RR, and therefore that is one of the observations we must understand. It may bias us in understanding a higher OR as compared to a real RR. So in this study, there are regulatory precedents to OR, and FDA wants an OR as well, and therefore that is being mentioned. But we must understand the prospective study, the best way to do is a risk ratio. If we were to do a risk ratio, this study would have given a risk ratio of 2.69 against an odds ratio, which was mentioned equivalent to 4.51. That's the first observation. Did they publish all what they said they would capture in their while registering the study? The outcome measures, the primary outcome measure was the MRD, and there were many secondary outcome measures. And if you critically analyze, duration of CR was not mentioned in the DR group. Overall survival, it is mentioned as a trend, but no data was there, and no quality of life was mentioned. And I'm sure this may come up in the future studies as well, future analysis, it might come up. Magnitude of clinical benefit scale is how much of a difference am I accepting for that p-value to be significant, and based on that the sample size is calculated, and then what is it. So if you look at the ESMO magnitude of clinical scale, just for you to understand a bit, I won't go into the details. For the curative intent and non-curative intent, there are various tools, and in fact that is for hematology as well. And if you look at and this is important for the HT analysis, especially cost effectiveness of the study, this is an important aspect. So they grade it as, in a curative setting, ABC, non-curative 1 to 5, and substantial benefit is 4 to 5. So in hematological malignancies, if you apply the same rules here, in this particular study, if we were to use the PFS, and the form which has to be used is form 2A, and based on that, for the hazard ratio which we got for the PFS, it is eligible for a grade 3 MCBS grading. So that's point number 2. If we were to grade the evidence of grade the study for the evidence, and how do we then say certainty of level of evidence, it would come at a moderate level of certainty when it comes to MRD. And why would it be? So there are 5 parameters which we use. So risk of bias, inconsistency, indirectness, imprecision, publication bias. If you look at it, there is some imprecision there with regard to the hazard ratio, and if it favors the DR, however, look at the confidence interval, which is pretty wide. And that is the reason why it would, though the HR is 0.56 or 53, which is 47%, there is a wide confidence interval, and therefore there is a downgradation from 4 to 5. The outcome, that way the certainty of evidence is moderate here. Let's apply that in terms of the upgradation from the grade. So if you understand grade, it is downgrading and upgrading from a +4 status on the certainty of evidence. It gets an upgrade at the RR level. If you look at the RR, that is which we used, more than 2 gets an upgrade of 1, and therefore large effect size in the MRD negativity gives an upgrade 1. So ultimately, MRD negativity at a high level of certainty, PFS is a moderate level of certainty. Now, the question then is, so what? How do you grade this evidence to decision framework from the same group? Problems, benefit, harm, certainty of evidence we have looked at. And now we are looking at patient values and preferences. Patient values of durable remissions, MRD negativity seems to be good. Resource use is something which India cannot afford as of now. So Dr. John alluded to the pharmacoeconomics of it, 80 lakhs in 36 months. And therefore, 46 injections, if you have to give, it is almost 80 lakhs plus. Is it worth to add a 3 lakh rupees per 1% increase in MRD negativity is the moot question at the root point you are going to ask. Can't I continue with some of my consolidations, try and bring them to an MRD negativity with lesser expensive tools post ASCT? That may be a better strategy for India, because right now we may not have the resources except for offering it to patients who can afford, because the out-of-pocket expenditure is very high and it is not insurance covered at this high level. Equity impact is high here because limited access. It is not possible to be given in government hospitals. Maybe ECHS, CGHS, some of the army hospitals may be able to afford it. But again, if you do an HTA for the health budget we have, it may not be the right choice. Feasibility, yes, it is feasible, but we do not have the monitoring infrastructure, as you mentioned, to do the MRD5 with from the genomics level of detecting this. We are barely there with flow cytometer. Acceptability among stakeholders, patients are likely to accept it, but payer concerns will be high. So with that, we can ask the question, what is good for the goose? Is it good for the gander? I would leave it at that, and we may be our esteemed panelists who may discuss whether it can be utilized for us or not. Thank you so much.
Yeah, that was a very nice statistical analysis. Actually, some of it went above my head, but definitely, I think the moot question which you raised has got relevance, especially with respect to our country as a reality check. And with that, I think we can ask for comments from the first author itself. We are lucky to have Dr. Badros with us.
Yeah, thank you for the invitation. Very impressive presentations, I have to admit. I appreciate it a lot, and I cannot comment on the odds ratio and odds or risk. This is beyond my abilities. I think just 2 comments. I think we are moving in the myeloma world today to a limited duration of therapy. And our previous approach of indefinite use of Revlimid is now being replaced by limited duration of therapy, whether it's 2 years or 3 years. And I think this trial really one of the first to show that limited duration of maintenance up to 3 years does improve the measured outcomes. And these are MRD negativity, CR rate, and there is 47% risk of progression in the treated patients. I really do appreciate the fact that MRD is unavailable in a lot of places all over the world. And actually in many sites in the US, MRD is not routinely done for patients. So this is also a very new area for us to explore, mostly done on clinical trials. So your point is very well taken. Can that be done completely for everybody? I think it should be. And I think the cost of it will be justified by de-escalation of therapy in patients who are MRD negative and escalation of therapy in patients who are MRD positive, with the goal, and I know that will sound strange to say, but really curing multiple myeloma. We know that patients that achieve MRD negativity for up to 2 and 3 years have very long remissions. Actually, some of them are cured. We like to use the term cure in our site because about 20% of our patients are remission-free at 10 years. Most of you probably have seen recent data showing there is a potential for cure in patients who got cilta-cel or Carvykti, which is a CAR T-cell therapy in relapse setting, 5-year remission duration of 30% off treatment, so high-risk patients relapsing. So I think we are moving more into more intensive treatment with limited duration and trying to stop the treatment early or de-escalate therapy if the patient is in a deep remission, as shown by MRD negativity, and very soon will be shown by in the peripheral blood using high sensitive measures of
the discussion.
What's that?
What time is this discussion allowed?
I'm sorry?
Sorry, that was an interruption. My mistake. Pardon me.
Okay. So that's basically what I was saying. I think the data that we're looking at is very impressive. By itself, it's not enough to establish that daratumumab is a standard of care. But if you look at the collective trials, and I think the initial John, I believe, Abraham, presented very well the data about different trials, Perseus trial, Griffin trial. If you look at the collective data, adding daratumumab in maintenance setting, whether you have received daratumumab upfront or not, improves your MRD negativity by about 20 points and improve your PFS in those long-term trials. The other point I will make, and I know it wasn't presented in this particular paper, but it was presented in a follow-up abstract, showing that doublet maintenance with daratumumab and Revlimid is highly effective in high-risk patients. And this particular subset of patients that are considered high risk at diagnosis do not do very well, and introducing doublet maintenance for them will be important. The third point I will say, which was mentioned briefly, MRD can de-escalate therapy, meaning if you are MRD negative after 12 months of follow-up or two years of follow-up, we don't know exactly which one is the best one, but this maintenance of MRD negativity assure you that the patient will do well and probably will help you make a decision about de-escalation of therapy rather than continuing to the 36 months of maintenance that was done in this particular trial.
Is there any other comments? So if we were to take this to the real world, would we dissect this high risk and the non-high risk groups and address them differently? Especially like, in our country, when we talk about it, cost comes into play, and that is definitely relevant. Some people can sponsored patients end up getting it, and the non-sponsored don't get it. And even the cost for doing the monitoring is substantial here. So if you can do the risk stratification, and would it be a platform for another study?
I think so. I actually believe that patients with high-risk multiple myeloma should receive doublet therapy, whether that includes carfilzomab Revlimid or daratumumab Revlimid, which is a little bit easier because it's a subcutaneous injection and doesn't have the toxic effects of carfilzomab. The only thing I will mention is the new definition of high risk. You probably are aware that the International Myeloma Working Group updated the risk stratification, just published. We discussed that in the EHA meeting, and it was updated in a publication in JCO. And I think following this real high-risk definitions in the current era, the high-risk definition changes because of the new treatment we have, the quadruplets. And I think if you look at this high-risk subset of patients, I think it makes a lot of sense to give them doublet therapy, try to prolong the remission, and try to improve their outcome. Because if they don't, the median remission duration or PFS is less than 2 years. And unfortunately, when you relapse those high-risk features, unless you can take them to CAR T-cell therapy, you really don't have many options left.
Is there any other comments from anybody?
Sumit here. Again,
Yes,
I wanted to ask 2 questions. So that was a very insightful talk from Dr. John, followed by Dr. Joseph Johnson, and then Dr. Badros. So 2 questions, in the field of maintenance, while you use daratumumab here for patients who have not been exposed to daratumumab before, you use the same schedule of dara, once a weekly, and then once in 2 weeks, and once in 4 weeks. So I wanted to ask, when the disease is very low, only residual disease level, you feel that they can directly start at the maintenance dose of dara once in 4 weeks, and do we really want to reinvent the wheel with the same frequency as in we do? And this question is because just like McNamara was obsessed with numbers, we at India, many of us are also obsessed with numbers and costs. So that was the first question.
I think in our practice, first the Perseus trial, give the patients 3 cycles of DARA RVD, collected stem cells, did a transplant, and then give them consolidation therapy to finish 6 cycles. So we believe that 6 cycles of daratumumab is the best option. In real life and in the real world, as you put it, we give patients somewhere between 4 and 6 cycles of treatment. Beyond 6 cycles, it becomes difficult to collect stem cells on the quadruplet therapy. And we usually go to once a month after that. We don't go to reinduction with daratumumab. We just use it once a month with Revlimid.
So even in the maintenance setting, you would like to give it as you would do it in induction, the dara.
I'm sorry, repeat that?
So even in the maintenance setting, you would like to use the drug at the same frequency as you would do it for a newly diagnosed myeloma patient.
Yes, once a month. Yeah, we use it once a month. We don't give weekly for 4 weeks if they have for 8 weeks if they have received their upfront. But yes, it's given once a month.
My
Dr.
one more
There are
question.
some studies that used it every other month, but I think especially in the smoldering myeloma trial, we used it every other month on the Black Swan trial. But usually it's given once a month.
What do you feel about the high-risk groups who upfront get a quadruplet therapy with DARA in it? And in that, I'm talking of a futuristic model where you have the high-risk group identified upfront, and you're using a quadruplet therapy as the induction with DARA included. In this case, also, you think we can go with the same schedule, or it would be a little lighter post-transplant?
Actually, the high-risk group, if they get quadruplet therapy, they have more or less the same incidence of achieving MRD negativity. The problem is maintenance of MRD. The MRD is achieved very quickly, but they also lose MRD very quickly. If you look in our trial and the PFS curve that was shown, there is some drop in the DARA or the Revlimid for some patients that were high risk and stopped treatment. They relapse very quickly. So actually, we believe that high-risk patients, especially if you define high risk with a new criteria, especially with the deletion 17, extramedullary disease, or high beta-2 microglobulin, or combination two cytogenetic abnormalities with 1Q and one of the aggressive translocation like 414, 1416, and 1420, this subset of patients do benefit from continuous maintenance. So the high-risk patients, we really don't stop the maintenance program because they relapse very quickly. And I just want to say that this subset of patients that are truly high risk, we have a current trial looking at using teclistamab as maintenance. So we are looking at patients after transplant, and then we are giving them randomization between Revlimid, teclistamab plus Revlimid, or teclistamab alone as a bispecific, as an immune therapy, moving up front to try to improve the outcome of maintenance. So maintenance has become very important part of myeloma treatment. And all this maintenance trial have very specific duration. So it's 2 months, 2 years of maintenance with teclistamab. Again, you are absolutely right. Patients have more side effects. The benefit of it is going to be treatment-free duration until they progress later on. But we are escalating maintenance in high-risk patients, not taking it down. Even with quadruplets, because we are actually selecting patients very clearly. If you relapse after their RVD with transplant, high-risk features are usually the number one cause for patients to progress on the quadruplet therapy.
Thank you. So there are no more comments. I don't see any hands. Is any other comments? Okay. If there are no more comments, I want to give a big thank you to Dr. Badros for having participated and also interacted so wonderfully with all of us and answering all our suggestions and questions and doubts. And with that, I would request Sumit and Uday to go ahead with the journal scan pre-recorded presentation of Dr. Gupta from Rajiv Gandhi.
Can you hear me?
Yes.
Okay. So Neerav, are my slides visible?
Yes, sir.
Okay. So we regularly have an eagle eye competition on the basis of an article called as a journal scan article. And this time the best commentary was invited for this article, which is a recent Blood Cancer Journal article, Multiple Myeloma, monthly treatment of zoledronate beyond 2 years offers sustained protection against progressive bone disease, published last year in Blood Cancer Journal. Just to update about the process for those who are new to this, a recently published article is selected. We invite a commentary of 175 words before a deadline. Anybody, irrespective of designation from any part of the world, can send this commentary. And the best commentary will be selected by a team of blinded reviewers. And again, is that those who wins gets an opportunity to present his journal scan along with a certificate and some credit hours and an image lifetime membership. The purpose is that our young faculty should read the latest articles on plasma cell dysplasias, learn the art of scanning an article, critical appraisal, more related to editors from our country, and similarly get an opportunity to present in front of a good audience. So the winner for this month's journal scan in June 2025 is Dr. Himani Gupta. She is a senior resident in Rajiv Gandhi Cancer Institute, New Delhi. So hearty congratulations to Dr. Himani. So I request Nirav to play the recorded commentary.
Good evening, respected teachers and dear colleagues. I, Dr. Himani Gupta, second year DRNB resident in Department of Clinical Hematology at Rajiv Gandhi Cancer Institute, New Delhi, would be presenting this month's journal scan. The article chosen is in multiple myeloma, monthly treatment with zoledronic acid beyond 2 years offers sustained protection against progressive bone disease. This article was published in Blood Cancer Journal in April 2024. As we all know, one of the most devastating complications in multiple myeloma is severe loss of bone mass. Up to 90% of the patients eventually suffer from bone destruction, which may result in bone pains, hypercalcemia, pathological fractures, or nerve root compressions. In 2003, more potent bisphosphonate zoledronic acid was demonstrated to be non-inferior to pamidronate in reducing skeletal-related events in multiple myeloma. Later, it was demonstrated that zoledronic acid not only reduced the number of SREs but also increased the overall survival by 5.5 months. This is a broad overview of osteoclastic bone destruction. Multiple myeloma cells, they activate osteoclasts via IL-6. These osteoclasts lead to bone resorption via rank ligand pathway. Bisphosphonates, by inhibiting these osteoclasts directly, prevent the bone resorption. Bisphosphonates-induced osteonecrosis (BON) is a serious disorder where the bone, usually mandible, starts to dissolve. Prolonged bisphosphonate use increases the risk of BON. Limiting their use to a shorter duration can help reducing its incidence, but may cause multiple myeloma-related bone complications. The rationale for the study was the number of novel therapies for multiple myeloma have increased and so has life expectancy. Medication to prevent disease-related SREs are limited by duration of use of less than 2 years. The study was needed to investigate whether longer duration of the therapy is efficacious and safe. The primary endpoint of the study was to assess time to progressive bone disease in the 4-year versus 2-year zoledronic administration group. Secondary endpoints assessed were progression-free survival, overall survival, incidence of BON, and quality of life. The inclusion criteria were symptomatic multiple myeloma according to IMWG criteria regardless of bone disease status, signed informed consent, age more than 18 years, remaining life expectancy of more than 2 years. The exclusion criteria were previous treatment with bisphosphonate within the last 6 months, creatinine clearance of less than 30, known concurrent malignancies, known hypersensitivity to zoledronic acid, pregnancy or lactating women. The criteria for randomization were as follows: no progressive bone disease at least 3 months prior to randomization, and the patient should have received at least 12 infusions of zoledronic acid in the prior 2-year period. 193 patients were included in the study and they were randomized in 1:1 ratio, 94 in the observation group and 99 in additional zoledronic acid group. Now coming to the results, both groups were matched with respect to age, gender, myeloma subtypes, ISS scoring, and WHO performance status. Patients in both the groups were also matched for complete remission, VGPR, partial remission, stable disease, and progressive disease responses. Overall, 30 cases of progressive bone disease were observed in the study. The observation group had 21 and ZOL group had 9. Patients treated for 4 years had a significantly lower risk of progressive bone disease with a hazard ratio of 0.4 and p-value of 0.021. Most common progressive bone disease was multiple new or growing lesions, with observation containing 16 patients and ZOL group having 5 patients with p-value of 0.001. Number needed to treat was 7.5. There was no statistically significant difference in occurrence of MRONCH, with ZOL group containing 6 patients and observation group containing 1 patient. Important thing to note is 2 out of those 6 patients experienced symptomatic complication and they both were of grade 2. There were no observed differences in progression-free survival and overall survival between both the groups. The quality of life questionnaires were evaluable in 142 patients, although mean pain was in between 0 to 100 was slightly higher in the observation group, and there was no statistical significant difference in quality of life. 3 studies have assessed the role of bisphosphonates in multiple myeloma. First, MRC Myeloma 9 study was the benchmark that established the role of zoledronic acid in multiple myeloma with superiority over clodronate and improved overall survival, progression-free survival, and reduced SREs. Evelis study was similar to the present study and established sustained SRE-free survival with prolonged zoledronic acid use. The present study, a phase 4 open-label RCT, demonstrated efficacy with respect to reduced SREs and comparable progression-free survival and overall survival between the groups. Notably, the incidence of BON was similar across all the studies. In conclusion, this study supports the prolonged use of zoledronic acid to prevent the skeletal-related events in the patients with multiple myeloma. In spite of prolonged therapy, the side effects of the medication were similar in both the groups, signifying safety of prolonged zoledronic acid administration. Thank you.
Yeah, Sumit, please go on. Go ahead.
Yes, sir. So I'm grateful to the reviewers, Dr. Ankur Jay from Safdarjung, Delhi, and Dr. Pankaj Malhotra sir from PJ Chandigarh. So the Journal Club article for the next month on 24th July 2025 is the recent IMWG consensus on the definition of high-risk multiple myeloma, published very recently, 2 weeks back. And even our international faculty today addressed this article in few of his comments. The Journal Scan article for next month is again a recent article from Blood Cancer Journal about CD56 expression predicts response to daratumumab-based regimens. Daratumumab is routinely used in upfront as well as in maintenance settings, so it is important to know what predicts the response to this expensive drug. And finally, we move on to the quiz. Some excitement and some nervousness, but hold on your adrenaline. Over to Uday sir.
Can you hear me?
Yeah.
Sir, thank you, sir. So with the permission of the president. So I request all of you to kindly join the slido.com with this gaming code or scan the QR code to join. There's no restriction on who all joins. Faculty, juniors, seniors, anyone can join. And it's going to be a fun thing. We are going to have this quiz dedicated to daratumumab so that we have the basics of daratumumab very clear. And it's going to be very simple quiz of what we daily practice. So people are yet to join. We request all of you to kindly join quickly. I request Sumit also to join because that would act as a benchmark. He is one of those boys who has won the maximum number of quizzes of Image till date. Hari sir, Joseph Jones sir, everybody can join, sir. We just got a message that there are 111 live audience, whereas the number joined and quiz are only 13. I wait for another 30 seconds before we start the quiz. So request everybody to kindly join quickly. Aditi Raghav is a MBBS student from Army College of Medical Science at Delhi, and if she can join, I think the PGs and the DM should definitely join. Okay, without much further ado, I would like to start off with the quiz. So the first question, which of the following is not an FDA approved regimen for using daratumumab? Dara-VRD in NDMM patient ineligible for transplant, Dara-VMP in NDMM patient ineligible for transplant, Dara-KD in RRMM patient receiving 1 to 3 lines of prior therapy, and Dara-PD in patients who have received at least 2 lines of therapy. Okay, 10 of them have answered, and many of you have answered Dara-VMP this is not approved. So people have said Dara-VMP is not approved. No, actually it's the Dara-VRD which is not approved in NDMM patients. So this is not FDA approved for transplant ineligible patients. So if we look at the leaderboard, Dr. Grishma, followed by Karan, followed by Agya and others. Okay, so these are the FDA approved regimens which are in combination with daratumumab. So for the newly diagnosed transplant eligible patients, Dara-VTD is FDA approved. For transplant ineligible patients, DRD or Dara-VMP is approved. And for relapse refractory, DRD, DVD or DKD is approved. Unfortunately, though we use Dara-VRD as the commonest regimen, it's not among the FDA approved regimens. So let's get on with the next question. Those who want to join at this stage, they can still join. We have 15 questions in total. Which of the following is an FDA-approved monotherapy for daratumumab? So monotherapy post-transplant in high-risk cytogenetics, smoldering MM for delaying progression, patients who are double refractory to proteasome inhibitor and immunomodulatory agent, and isolated extramedullary relapse after CAR-T. This is the fastest finger which works, and also other than you answering it right, it has to be the fastest finger first. So again, though we consider that monotherapy is post-transplant in high-risk patients, so that's not a FDA approved indication. The FDA approved indication. So we have Karan leading the board. So based on the Sirius trial, the FDA had approved monotherapy for daratumumab in patients who have received at least 3 prior lines of therapy, including proteasome and IMiD, such as POM, LEN, or thalidomide, or patients who are double refractory to PI and IMiD. So that is the FDA approved indication for monotherapy for daratumumab. Okay. Go on with the third question. How does Dara-induced trogocytosis cause resistance to daratumumab? By increasing CD38 expression on residual tumor cells, by reducing target antigen density, by enhancing complement-mediated lysis, and by upregulating PD-1 on T cells. Okay, we have around 50% of the people who have answered it right. So by reducing the target antigen density. So trogocytosis, so in the leaderboard, Karan is still leading, closely followed by Grishma. So trogocytosis is the term which the way the amoeba engulfs the various external organisms to eat them. So that process is known as trogocytosis. So trogocytosis occurs when the immune cells remove the CD38 from the myeloma cells during ADCC. So thus they decrease the target availability. So this not only occurs with Dara, it also occurs with isatuximab. Over a period of time, there is an antigen stripping, and this leads to Dara resistance after prolonged usage of Dara. So studies have shown that CD38 expression drops significantly, and this is one of the important mechanisms for resistance to daratumumab. Also, people have said if a patient has developed Dara resistance, and if we wait for 1 year duration, so there is a possibility of regaining the treatment efficacy by re-challenging with the daratumumab or alternating it with another anti-CD38 agent, though it might not reach the treatment naive situation, but a 1 year gap can resume the sensitivity of the myeloma. Okay, let's get on with the next question. A patient relapses on daratumumab plus lenalidomide maintenance, DR maintenance after 18 months Flow cytometry shows CD38 negative. Which regimen is least likely to work? KD, Isapom, BCMA directed CAR-T, Selinexor plus Dexa. Least likely. So we have a divided poll here. So half of you feel that it's isatuximab plus pomalidomide, and half of you think it's BCMA directed CAR-T. So because as I just told you, in DARA resistance, because isatuximab is also CD38 positive, anti-CD38, right? So CD38, when the density decreases, the chances of ISA to work in patients with DARA resistance is low. So current, you are still on the top. So isatuximab, this is what I was saying. Rest all options, that is BCMA CAR-T, selinexor, or other combinations, anything can work, but not isatuximab. So it will not be of same effectiveness as that of other modalities of therapy. Let's get on with the next question. A patient with eGFR of 20 ml per minute, that is renal dysfunction, is started on daratumumab. What is the dose adjustment you would advise for this patient? Decrease the dose by 50%, 25%, avoid subcutaneous formulation, or no dose adjustment is required. Excellent. So we all understand DARA, one of the indication happens to be patients with renal dysfunction. So no dose adjustment is required for daratumumab. So that's the drive home point. We have a change in the leaderboard. Wonderful. So because it is metabolized by proteases and not renally excreted, so pharmacokinetic studies have confirmed that there is no need to do dose modification in renal impairment, including patients on CRRT, peritoneal dialysis, hemodialysis, anything. Okay, let's get on with the next question. A patient on DARA develops recurrent CMV viremia. Which immune parameter would you assess? CD4 cells, CD56, NK cell function, CD19 plus B cell levels, or complement levels. CMV viremia is a common problem with daratumumab. So I agree with the majority. So the answer is CD4 plus T cell count. So that's what needs to be assessed. And because daratumumab depletes 38 plus 4 plus T cells, thus increasing the chance of CMV reactivation risk, whereas so monitoring of CD4 is recommended in such situations, while NK as well as B cells do not have any relevance as far as DARA action is concerned. Okay, let's get on with the next question. 65-year-old male develops rigors, bronchospasm, hypotension during the first DARA infusion. The pre-medication was given as advised. What is the next best step? Discontinue DARA permanently, administer IV epinephrine and halt the infusion, slow the infusion rate, or switch to subcutaneous. Excellent. So 62% of the people say have answered it correctly. You just need to slow the infusion rate. So, okay, this is the leaderboard after 7th question. So for grade 2 reactions, the guidelines recommend stopping infusion, giving additional steroids, and restarting at 50% of the infusion rate, the speed at which we are giving. Epinephrine is reserved for anaphylaxis. And if any person develops anaphylaxis, grade 3 or grade 4, then we discontinue DARA permanently, the intravenous formulation. They can be given a challenge with subcutaneous. But otherwise, anaphylaxis is absolute no-no for giving it again second time. Okay, let's get on with the next question. 58-year-old male, translocation 11-14, was on DARA-RD. After 14 months, developed a relapse. Hematologist considers venetoclax because it's translocation 11-14. What is the strongest rationale for considering venetoclax? You have 1 minute for answering this. It's not 20 seconds because it's a long question. Practically, we are asking what is the mechanism of action of venetoclax in translocation 11-14 multiple myelomas. And this is based on the work, extensive work by Dr. Shaji Kumar. Excellent. So most of you have answered it correct. So the translocation 1114 leads to CCND1 overexpression, which directly activates BCL2 dependency. And there is a role of BCL2 dependency. In the Bellini trial, they have shown that that helps. That's the reason of giving venetoclax in these patients, in this subset of patients. Let's get on with the next question. Why is DARA less effective in extramedullary disease? EMD cells lack CD38, poor antibody penetration into soft tissues. EMD upregulates the complement inhibitors, and tumor microenvironment shields EMD from ADCC action. No. So we don't agree with the majority. The answer is poor antibody penetration. That is, the monoclonal antibody does not penetrate well into the soft tissues because they have a impaired vascularity. So they do not have the same amount of vascularization as that of the other lesions. So it limits the monoclonal antibody delivery, and that is why the DARA does not work well. And same happens with teclistamab also. So there have been extensive reports saying that teclistamab does not work well with EMD for the same reason. The CD38 expression is typically preserved, making antigen loss an incorrect explanation. Okay, let's get on with the next question. Patient's myeloma progresses rapidly within 2 months of starting DARA. Which biomarker predicts this? So a patient is DARA refractory. So what it would be his characteristic? Excellent. So TP53 is the right answer. So TP53, there are enough studies to explain how TP53 is refractory to various regimens, and of which daratumumab has been clearly shown that patients with TP53 have a median PFS of less than 6 months on daratumumab. Okay, let's get on with the next question. Which of the following best explains why anti-CD38 naivety was a key inclusion criteria in the Auriga study using DARA? Again, we have given a slightly more time in this question because you need to read all the answers. So it's for 1 minute. So we agree. So this is what was discussed. Previous anti-CD38 therapy reduces CD38 expression, limiting DARA efficacy. So the leaderboard is more or less constant. Okay. Let's get on with the next few questions. So DARA treatment is known to interfere with which of the following laboratory tests due to its mechanism of action? It modifies beta-2 microglobulin levels. It modifies SPP, SIFE. It modifies FISH. It modifies bone marrow aspirate cellularity. So this I expected 100% of you to answer this correct. So as we all understand, the IFE reports, you will still find some IgG kappa fraction, which is seen in these patients, and some amount of M protein would be seen in those patients because on daratumumab. So that's the correct answer. So daracomigration. So the best way to evaluate such patients is to do a mass specs. We have the last 3 questions. What is the vial strength of daratumumab available in India? 400 mg per 20 ml, 400 mg for 50 ml, 600 mg in 20 ml, and 600 mg in 50 ml. So of all these things, which is the best option? For all those who have been using daratumumab, that should be an easy one. Oh no. So I don't agree with the majority. So it's 400 mg per 20 ml. We have two oil strengths in our country. So it's 400 mg per 20 ml or 100 mg for 5 ml. So it's basically 20 mg per ml is the strength that is available. Again, the last two, DARA plus hyaluronidase, that is the subcutaneous preparation, requires renal modification, unlike the intravenous. Is this statement true or false? So IV, we have just spoken that it does not require any renal modification. So correct. So most of you have answered it right. Again, subcutaneous also does not require any renal modification. Some people do have this confusion that because it is hyaluronidase and does it might require, it does not. The last question for the day. The dose of DARA intravenous and DARA subcutaneous is the same, true or false? We give 16 mg per kg for DARA intravenous. So it's the same for DARA subcutaneous as well. So again, we agree with the majority. So the dosages are different for both of them. So with that, I am not sure who SM is, but you are the winner. So you can claim your prize with us. You can write to me or to Dr. Sumit, either of us. And the hardest question today was, why is DARA less effective in extramedullary disease? Only 21% of the people have answered. So with that, we come to the end of this phase. I would like to hand over the stage back to Dr. Sumit. So we don't
Hello, sir.
Yeah, Sumit. Yeah. Over to you, please.
So we are very grateful to the national moderator, Dr. Joseph John, sir, Dr. John Ibrahim for presenting the Journal Club. Dr. Badros, I'm not sure if he's still around, for joining us at an unusual time in his country. And most importantly, the first time winner of Journal Scan today, that is Dr. Himani Gupta. And lastly, Dr. Velu Nair sir for moderating the proceedings. And importantly, Dr. Uday sir for the wonderful quiz. Many simple questions, but still many people make mistakes. The next Journal Club Journal Scan webinar will be on 24th of July. And we've already announced the Journal Club and Journal Scan articles for the same. Over to Velu sir for the vote of thanks.
Thank you, Sumit. Actually, we had a wonderful Journal Club and Journal Scan and a very exciting quiz. I would give a big thank you to Professor Joseph John and his team with John Abraham. And obviously, a very big thank you to Dr. Bedros from overseas, who has joined us in a little odd time, but he really participated in the Journal Club. And I'd like to congratulate Dr. Himani Gupta on a Journal Scan presentation, which was crisp and nice. And SM, write your full name, who's the winner for today's quiz. And I must thank Uday and Sumit for having put this together, and for all the people who participated. Thank you very much. Till we meet again next month. Jai Hind.
Jai Hind, sir. Sir, I think SM is Sumit.
Oh.
I did not want to disclose it.
Okay. So next time you write MS. Okay, congratulations. So for the nth time you won it. Anyway, good show. Thank you.
Thank you all, sir. Jai Hind, sir.
Bye, sir. Bye.
Thank you. Thank you, Joseph.